All right. Perfect. Excellent. Well, I do have 12 o'clock Mountain Time, so I'm going to go ahead and get started, even though I know folks are still trickling in. Welcome, everyone. My name is Jen Anderson. I'm the Clinical Quality Improvement Director for CHANCE. I'll be your moderator for today's event. Community Health Association of Mountain Plains States, or CHANCE, is your Region 8 primary care association. Of course, you all know we serve the states of Colorado, Montana, North Dakota, South Dakota, Utah, and Wyoming. We are really excited to welcome you to the second session of our Region 8 Identifying and Responding to Intimate Partner Violence and Human Trafficking series. This series is a joint effort between all of the state primary care associations in Region 8, the Association for Utah Community Health, Colorado Community Health Network, Community Healthcare Association of the Dakotas, Montana Primary Care Association, and Wyoming Primary Care Association. The session that we're focusing on today is on operational considerations, organizational guidelines for screening for intimate partner violence and human trafficking. Our speaker today is Heidi Hart, Chief Executive Officer for Terry Riley Health Services, a community health center located in the Boise, Idaho, and surrounding areas. You can read more about Heidi and all of her accomplishments in the handout. So if you haven't already done so, you can download the handouts for this event via the Zoom chat feature. They're available to download. These documents also include the slide deck so that you can follow along. As I mentioned before, please do rename yourself so we can identify you. This will help us with our attendance and help you to help you when you guys have any problems. Please also feel free to ask any questions of our speaker today in the chat box. We are going to try to address those as they come up, and if not, we will try to get them answered by the end of today's session. So please don't hesitate to ask your questions as we go along. Today's session is being recorded for future reference. The archive will be available shortly on our webpage. And if you need technical assistance at any time, please do message Katie Chamberlain, who's labeled as Tech Help, and she'll help you out as soon as possible. And with that, I would love to turn our presentation over to Heidi. Heidi, welcome so much. Welcome to our presentation.
Well, thank you for having me, and thank you everybody for being on the meeting this afternoon. I appreciate the time to be able to be here with you and to share a little bit about the journey of our health center as we have looked at ways that we can respond to intimate partner violence and human trafficking within our health center patients. A little bit about me, because I always think it's helpful that you know a little bit about me and who I am, because I think it shapes the philosophy or orientation, I suppose, that I bring to leadership at our health center. I have been with Terry Riley for about 30 years now. I started out as a grad student and then as a counselor working with what we called our SANE Solutions program, which was counseling for victims of sexual abuse, sexual assault, as well as adult and juvenile sex offenders. And then I've been the CEO for the last 14 years or so. And I share that because I believe that one of the things that I bring as a leadership to my role and to our health center is really an understanding of the importance and the prevalence and the impact of trauma. And how that affects the lives of the patients that trust us with their healthcare needs. So that shapes my worldview, it shapes my philosophy, and it is in there in the way that I think about how we as a health center respond. Everybody that's in leadership and everybody in an organization bring their own kind of biases and histories. And so I think it's helpful that you know that I come into leadership with a bias or understanding around behavioral health and social determinants, and thinking about how I weave that in to the leadership that I bring to our organization. There's some things in here that we wanted to be able to share, or I wanted to be able to share with all of you today. A little bit is about Terry Riley. Again, from a context setting, I think it's important that you know about our health center, but I also think it's important that you know our why. Not every health center provides services or thinks about prioritizing intimate partner violence and human trafficking. So I wanted to share the why, about why this was important to us and why it was part of our call to action, and why now, because I think that everything, there's lots of things that come at us and we have different times and places to think about what's a priority. So I think it's important that we shared our why and how this became a priority for us. As well as our thinking about our approach, and if we were going to provide services or interventions or screening about IPV or human trafficking, what was the paradigm or the model that we used as we went on our journey to be able to do this? work, and then thinking about how we set the stage for screening to make sure organizationally we were prepared to be able to do the work, how we implemented screening, and then how we support individuals. Our work is not done. This is really a journey within every organization as we think about how we continue to grow and evolve. So like everybody, there are things that we need to continue to work on. So I don't come to you today in a place of saying our work is finished. I'm here to share with you where we're at in our journey as we think about how we continue to grow and evolve. As Jen said, it's really different to be able to be a presenter on Zoom with lots of people out there. You don't have the same opportunities to have interactions, but to the best that I can, I would ask that you feel free to put things in the chat to be able to message things so that we can respond or I can share feedback or thoughts as we go along. It's the best tool that we have to be interactive as we're going through this. So please do. Jen's going to help me watch the chat, and I've told her to feel free to interrupt me. I tend to talk fast and I feel like I have a lot to share with you. So she has the green light to interrupt me and say, hey, there's something in the chat that we want you to pause and share a little bit more about. So please do use the chat feature. A little bit about Terry Riley. Like all of you, we're a community health center dedicated to affordable, accessible, quality healthcare, thinking about how we respond to the needs of our community. Our health center, just for perspective, this is the state of Idaho. We're in the Boise area, so southwest. There are about 15 health centers across the state of Idaho, taking care of about 228,000 Idahoans. And I think one of the things that I love about our state network, and I think is probably true for your states as well, is that we work really well together, thinking about how we're taking care of not only our patients, but our state. So the conversations and the work that we're doing is not unique to Terry Riley, right? It's done in partnership with all of you, with other health centers in the state of Idaho, but as well as health centers around the country. In the Treasure Valley, this is if you narrow down into the map, our primary service area is Boise, Nampa, Caldwell, and then the surrounding areas. We call it the Treasure Valley, but for us, it's medical, dental, behavioral health, and pharmacy scattered all around Southwest Idaho. We are getting ready to celebrate 55 years of service in the Treasure Valley as a health center. And by size of organization, we have about 550 or so employees and about 73 million in operations. Our team is really grounded in making sure we use evidence-based standards or benchmarking to make sure that we can define and describe what quality means and to have a roadmap for programs and services that we want to put in place. So for us, that means we look to Joint Commission, CARF, NCQA, and SAMHSA around CCBHC to create our paradigms. So some of the language or things that I talk about, you may see flavors of that in our work. As I said, we have about 41,000 patients or so in our practice, taking care of about 182,000 appointments. One of the things that's interesting about our practice is that just about half of our clinics and patient care services are medical. There's about 25% behavioral health, about 25% dental. And I share that because, again, it's reflective of my philosophy or paradigm, and that we're pretty heavily invested in behavioral health services and the work that we do. And I think that that's a little bit different than other health centers. But our behavioral health team is really a core part of the program and services that we offer. And I would say the other thing that kind of stands out in our health center is that we're a pretty adult practice. We have about 5,000 or so patients in our practice that are pediatrics, but generally we are an adult patient population across all of the service lines. Again, not exclusively, but most of the people that we take care of are adults. And so thinking about what are the needs of adults is a little bit different than if you're really heavily involved in pediatrics. Like all of you, we focus on core services around medical, dental, pharmacy, enabling services, and behavioral health. But there are some things that we do and programs we've developed over the years that are special around behavioral health. And they are part of why we started to work on intimate partner violence or human trafficking. In behavioral health in particular, we have some counseling centers where we focus specifically on providing long-term counseling for people who are victims of trauma or sexual assault or domestic violence, as well as the treatment program for offenders. So this idea of working in the space of trauma has been part of the ethos of our organization since about 1983. And so it's really ingrained into the philosophy and beliefs and programs and services that we have. And again, that is something that is a little bit unique to our health center, but I think it's part of the shaping about why or how we were able to enter into the space of bringing some of that good work into more of the primary care space when we think about IPV and human trafficking. Um, again, a little bit on our why. Philosophically, for me, I believe as a health center, we stand at the intersection of primary care, social service, and public health. And that we all know that trauma and IPV are factors that impact the health and well-being of our patient population. There's lots of data, and I just put one slide in there about the data that talks about the importance or the long-term ramifications around physical health, social health, and primary health conditions. And so my guess is that none of this is new, and you guys have seen a lot of the same data. But that wasn't really what was our compelling call to action, right? It was, yes, the data was sitting there. Yes, it was part of our philosophy. But realistically, we were responding to some concrete needs of our patients. And these were incidents that happened within our clinics within a really short period of time. And it was our staff that were coming forward and saying, there are some things that are happening that are making us uncomfortable. And we feel ill prepared or equipped to be able to take care of our patients, and we don't know what to do. So the real call to action, regardless of all of the programs we had or the services or the philosophy I might bring, was our staff members saying, we need to work on this because we need to be able to help. So some examples of things that happened, and these all happened in a really short, relatively short period of time. So some of the first ones were coming out of our urgent care clinics. It was the front desk that noticed this, that there was an adult male who was bringing young women into our urgent care for family planning visits. He was the uncle of many of these young girls, or that was how he identified. And we have 3 urgent cares, and this same man was bringing different females to 3 different urgent cares. And it was front desk members who were floating between clinics that noticed and identified that this didn't feel right. They couldn't label it, couldn't describe it, but something was wrong about this man that kept bringing these girls. These same people working the front desk also identified that there was an adult male that was bringing young teen boys into the urgent care clinic, and they were being tested for STI and STDs. So it was really a front desk response that were coming to leadership. They were getting hold of some team members and starting to be worried about some of the young adults that were being brought into our clinic. We had a clinic where an employee had a husband. They were in the midst of a separation. There was an order of protection, and he said he was going to come to the clinic and he was going to kill her and anybody else who was there. She shared that with the clinic staff, and then people asked the question about, so what do we do and how do we be safe? We had a patient that wrote help on the back of a registration form as she was filling out her paperwork, and she gave it to the front desk team member as she sat back down in the lobby, and we have front desk team, and they have this registration form, and they didn't know what to do. We had another incident where an adult female presented with her kids. The team checked them in, roomed them, took her back in to start the visit, and her male partner arrived. And like most of you, we put up glass at reception during COVID, and we chose to leave the glass up because it was helping our front desk members feel safer. And this gentleman arrived at the clinic, and he was banging on the glass and on the doors and shaking on the door trying to get back into the clinic. And our team didn't know how or who was supposed to respond and how to stop him. We had a client walk into one of our small rural clinics and tell the front desk that she was a victim of human trafficking and wanted help. We had a female employee at a clinic who disclosed that she was a victim and asked the team member to help and tried to get resources through HR to start to get the human resources team involved. And during a relatively close period of time, we had 2 community shootings. One was at the local mall, which is close to a couple of our clinics, and one was in the emergency room. In the emergency department, there was an inmate that was being transported from the prison to the hospital for services, and there was a shooting in the emergency department before he fled and was on the run until they were able to capture him. So our call to action was not about, like I say, data. It was our patients were coming to us because they knew that we were a safe place where we could help them. Our team wanted to be able to help them, and we did not have the systems in place to be adequately responding to and supporting the people who trusted us for the care. I share all of this, and people are like, oh my gosh, you had all of that happen in a short period of time. And the answer is yes, we did. We had been creating safe space, relationships within the community. We're a trusted source of care. And it was a privilege that our patients would see us this way and would turn to us to help. But we also knew we had a responsibility to be able to do something in response to that trust that they placed on us. So that was truly our call to action. So one of the things, oh, sorry, one of the things that we had to work through is to say, but what is it that we're going to do? Our patients are asking us for help. They're wanting to have us help them, and we need to think about our structure. There's actually a really good tool set that I believe is still out on the HRSA website. They have a toolkit about preventing and responding to intimate partner violence and how to create a framework to help implement services and screening within health centers. They have a 5-step building block. I'm going to walk you through a couple of the building blocks that we used, and I will tell you we didn't follow them in order. But it's a really great toolkit that if this is something you're looking to implement, I would encourage you to read it and think about whether or not it helps create the structure that you want within your health center. The building blocks I'll walk you through a little bit was the first thing for us is that we had to take care of our employees. We needed to invest in support and training for them. And then we needed to think about how we were going to implement screening within our health center. And then it wasn't enough that we had screened it. People always said, but what are we going to do if we have somebody? It's not enough to screen and know. We have to be able to hand them off to somebody so that they get the help that they need. And then the last piece that I'll weave in here is that you can't do this work alone, or we can't do this work alone. And so there were lots of key partnerships and relationships that we had to develop along the way to reinforce our ability to work within the ecosystem that we have within our local community. So training and workforce support, one of the first steps we went on was a journey about creating training modules or training that we could begin to create language within our workforce around interpersonal violence and human trafficking. So we put together a variety of trainings. These became required trainings across our entire workforce. It was trainings around what is trauma-informed care, what is interpersonal violence, what is human trafficking, um, respectful language, and then also introducing some fundamental skills for all of our workforce around de-escalation, mental health first aid, safe talks. And those were for everybody. And then we have created ongoing trainings that people can participate to continue to develop their skills, but then also for new employees. So our training team spent a lot of time working with our behavioral health leadership, develop training that we could begin to have a shared language and a shared understanding of our why across the organization. We also really had to appreciate that this is hard work, and that for some of our employees, as you saw from some of our examples, some of our employees are struggling with or working through issues around intimate partner violence in their own relationships and at home. So there is an opportunity or a potential that we are triggering for them, and that we need to make sure we're supporting them. So whether it was personal or professional, we needed to make sure that we had support in place for our team. And what I would say is that through our EAP program, we get utilization data. And what we're seeing as we continue to support investment in our workforce is that utilization in our EAP is going up, which to me is nice that people are taking advantage of the resources. But for us, what we were trying to do is make sure we're investing in safety within our employees if we're asking and starting to talk about fragile or dangerous or worrisome situations within our patient population. One of the other investments we had to think through when it came to workforce support is I will point you to the U.S. Surgeons General because they have this model that they put forward, which talks about how you create the essentials for workplace mental health and well-being. And I think we as leaders, we spend a lot of time talking about 4 of the 5 domains. We talk a lot about, do people have opportunities to learn and grow? Are they doing work that's important? Do they have work-life balance? Do they have a sense of belonging? We don't talk a lot about, and do they feel safe at work? So for us, we also wanted to make sure that if we're talking about and creating safe space around safety, that our employees felt safe. And one of the things that we found was in following up on some of those incidents that we had is the answer was no. People actually didn't feel safe in general in the world and in the work that we do. And I would say this is different for every health center, right? So you all will do assessments for your own workforce, but this was one that was really important to us. At the end of the day, and I know that this is a little bit controversial for some of my colleagues, but we ended up investing in safety personnel. We have 3 retired law enforcement officers. They are plainclothes officers that work across our system doing elbow support training, walkabout safety training. They do standbys for anybody that requests that there's somebody on standby if they're worried about something that will happen. They're connected with the hospital security teams. They have connected us with 911 if we have an emergency. They are running a lot of our codes and drills, and they are constantly looking about how we create a safe workplace. So I put that out there because this was something in our world that was really important if we were going to talk about human trafficking and interpersonal violence. And we think about the incidents we had, our staff had to feel safe. And then we wanted to continue to make sure that we were a safe place in the community. So we have invested in a lot of community trainings. And these are the 3 training modules that we promote and make available within the community as good partners about making sure that we're integrated into the fabric of the community. So having set our why and created an ecosystem, then we felt ready to start to think about implementing screening and education. But it wasn't until we felt like our workforce was ready that we could begin to open up the door to patient screening and education. We have 2 ladies on our team who were champions of this work. They continue to be the champions of this work for our organization. And the first thing that they did was go to some trainings to make sure that they understood protocols, policies, procedures, tools that they could bring back to our organization. And one of the bodies of work that they created for us was a protocol that is unique to everyone. There's consistency, but it is also unique to every clinic that we have that talks about what is the clinic response, because every clinic is a different size, has different people, has different geographical locations, different resources. And so we couldn't have one protocol that was appropriate for every clinic. We had to make it tailored. And then those 2 ladies went and provided care team training at every one of our clinics to begin the conversation and to implement the protocol that we now have in place. We chose to base our protocol not on screening questions. So if you come into one of our clinics, we don't ask you your PHQ, and then the next question isn't, your smoking and your drinking habits, and then are you a victim of interpersonal violence? That wasn't an approach that worked for what we wanted to implement in our organization. Our protocol is either based on patient self-disclosure or staff having concerns based upon warning signs. So we had to spend time educating our team members about what they might watch for that might be an indicator that they might need to ask the questions. So everybody has to think about, as you're implementing this, what is the protocol and how is it that you want to open the door to conversation? And this is how we chose to do it within our practice. But what we also know is that once you observe something, not everybody is going to have the same skills or confidence in being able to help support the individual and to have those opening conversations. So we identified a first responder at every clinic. So anyone can identify somebody that they're worried about, and then they do a handoff to a person. And depending on the size of the clinic, there might be multiple people, and it is that person then who's able to open up the door. Because what we found is not everybody is comfortable with these conversations. Not everybody is skilled in these conversations, and not everybody wants to be the one that opens the door with the patients. For our model, and you're going to hear Dr. Chang, I think, next time you guys meet, and she'll help share some tools that are available. But in our program, we used two things. One is the pair, and the other is cues. And so those are things that you'll hear more as you're continuing to do this work. But we really thought that those two were the best that we could blend together that worked for our practice. So I would say one of the secondary things is not only like how you want to think about implementing screenings, but what are the tools that you want to use to help support your team and the patients. So for us, here's some examples. As I said, the two ladies did a lot of training, went out and did elbow support with all of the clinics. Our safety team is coming along beside to help reinforce. We had to create some tools and resource guides that are available to all of our staff. So these are examples of two. The one on my right, or I think it's still on your right, is step by step, make it really concrete. Here are the 4 things that we need you to do. If somebody discloses or you have concerns, get your first responder. It's that simple and easy. They will work with the provider to decide what to do, and then they will decide if there's responses. So it was really step by step, because what happens when something services is people get really anxious and worried. And so we needed to make it really concrete, very systematic about here are the next steps and here's what you need to do. So there was no worry or concern. The document that's on the left, this is a laminated document. It's at every one of our front desks. Everybody has access to it. And it's a way that we keep things front and center for all of our team members about things to look for and things that they may want to think about. And so part of it too is helping to reinforce that our front desk team members are not just there to facilitate the paperwork process, right? Yes, they have registrations to do. Yes, they have forms that they need to fill out, but really they are the eyes and the ears about what's going on in the lobby and the first source of data or information about the patient that's coming in. And so we needed to make sure that they felt equipped and supported, educated, and have tools and resources to help them be those ambassadors of bringing patients into our practice, in addition to the transactional work that they needed to be able to do. Oh, my screen is blank. I guess I don't have anything there I'm supposed to show you. Oh, the pairs is the tool that I alluded to that we use to help with the screening. It is a really concrete, easy guide that our team liked. They liked the use of language that was in it. They liked the steps that it went through. And again, much like for the front desk, it was 4 concrete steps about you do this, and then you do this, and you do this. So again, in the heat of an emotionally stressful potential situation, it created order and structure that we could teach across disciplines. So for us, this was the tool that our team felt the most comfortable using when we were thinking about training our first responders. We had to go through and think about how to document the pair. And I have to say, the pair we got it from Dignity Health. So that's where the pair tool came from. But we ended up having to then create in the electronic health record a way to document the intervention or the interaction with a patient. So we have epic flow sheets that follow the pair. And it is a way for the provider team or the first responder to be able to document their interaction with a patient when they were having a fragile or difficult potential conversation with a patient. So for us, again, you think about it. First, we had to create an ecosystem where we could have it. We needed to document and have policies. We had to equip our team members. And then we needed to think about how we were going to then share and reach out to patients. So all of that is work that we did before we ever did any kind of education with patients. We use the Futures Without Violence documents for our patient education material. And that's what I alluded to with Dr. Chang, that she'll share more. So I didn't want to put too much in here so that it's really a teaser for when she joins you next month. But the Q's material was the right material and information for our practice. Because it helped us they have two little cards. Part of the conversation is you give everybody two little cards that have a bunch of information. And it's really saying for providers, this is something that I give to all of my patients so that you can help pass the word about us being a safe place. So we really liked the norming language and the safe place language that was embedded in the Q's material because it was consistent with the messaging and the philosophy or culture that we were wanting to create for our patients. We went through and put signage in every bathroom and in every exam room and every clinic. So if a person wasn't wanting to make a disclosure directly with one of our team members, that they had access to the national hotline and could get help through other ways. So that became something that we standardized across all of our clinics. And then again, this is the Futures Without Violence, and they have all kinds of information that's available on their website at no charge. So our team went through and picked some of the material that we thought was most appropriate in the language and design of material that fit within our practice. And again, I don't want to take too much from what Dr. Chang's going to share with you, but their resources and information at their website for us was really phenomenal and helpful educational material because we didn't want to have to think through how we create or design it ourselves when this is something that they are really spending a lot of time, energy, and resources in developing. So again, the pairs for the screening on the provider side and the cues for the patient education were the two ultimate patient-facing interactive resources that we provided when we think about how we structured the model that we have in place. One of the other things that was important for us was we know that not everybody comes through our front door. So we put a tab on our website, which is essentially a safe space page. So if somebody has the ability to have access to the internet, then they can come in here and they can request a confidential appointment or communication with one of our patient navigators. And then that person will help them navigate through our system without having to call our call center, without having to walk in. So we were trying to think through what are the different ways that patients may want to try and reach us as a safe space. So again, whether it was walking in or through a technology medium, we wanted to make sure that we had found some different ways to reach out to our patients. We had to think through our partnerships because you can't do, or I don't suggest doing this work in a vacuum, that there's really a lot of different entities that have connections to this work. So for us, that was Idaho Anti-Trafficking Coalition, making sure we had relationships and agreements and had connectedness so that we weren't duplicating or creating confusion because one of the last things we wanted was for somebody to trust us and then we don't know how to access the rest of the ecosystem to help people. We worked closely with both our Ada County Victim Services Center and our Nampa Family Justice Center, which in our community are the hubs, which are a one-stop place for somebody who is a victim of a crime to get all of the resources they wanted. And then thinking through financially some other resources that could come to the table to help people, and that was the Council on Domestic Violence and Crime Victims Compensation. So trying to think through some of the key stakeholders that wrapped around and helped supported the work that we do. There are one of the things that our team, as I mentioned in the beginning, we were worried about is if you identify and you help people access external resources, that's one thing. but there's also things that we can do within our health center to make sure that we're providing follow-up care and counseling and supportive services. So in this space, we have trauma counseling, but also treatment for adult and juvenile sex offenders and batterers. I'm not going to talk about the latter two. I'm going to talk a little bit about our trauma counseling services because it was really important that we made sure we had really good internal referrals and handoffs because we could do screening in the clinic or we could identify somebody and we might have long-term counseling. But if we can't seamlessly bridge within our organization on internal referrals, then we were doing a disservice. So not only did we have to look at external relationships and connections, but also make sure that we were being patient-centered in our internal referrals and the work that we could provide to come to the table to help support our clients. In our organization, we have 4 counseling centers that are all dedicated to supporting people who are victims of human trafficking, interpersonal violence, sexual trauma, or trauma in general. They're scattered across our service area. They're separate counseling offices. They are not integrated clinics, so they are not co-located within our primary care practices. They're solely focused on trauma, and we call it trauma and resilience centers because that's where we want our clients to live. We have 14 trauma therapists, and these individuals provide both virtual and in-person therapy, as well as DBT and protective parenting. And I'll come back to the protective parenting. Right now, we're finding that people are in care between 10 and 12 months or 6 for protective parenting. And what that highlights or reinforces and reminds us is that recovery is a journey and it takes time. And so we have worked really hard to build out our system to make sure that we give people the time and space that they need to get the support that they need to recover and find their resilience best self. The main treatment modalities our team uses are EMDR and DBT. So those are the 2 main modalities, although like with kids, you'll use play therapy and some other modalities, but for the adults, those are the 2 main therapeutic models that we provide to the patients that come to us. Within the world of human trafficking, one of the things that we put in place, that I mentioned, is the partnership with the Idaho Anti-Trafficking Coalition. One of the gifts that the Anti-Trafficking Coalition is able to bring to people who make a disclosure on human trafficking is crisis response. So I would say that is not a place where we stepped in and chose to develop our services because when we looked at community strengths and resources and needs, this was not a need. It was a strength and gift that they had that they could provide. So that is the group. If you think about the referral pathways, if we disclose have an individual that discloses and needs help, the external pathway to the Human Trafficking Coalition helps for shelter, supporting people through the legal process if they should choose to, if they need orders of protection, all of that safety and security, whereas they come to us for counseling, medical and dental or psychiatry services. So it becomes a shared plan of care that you have to manage or we choose to manage pretty closely and carefully. We have one individual on our team that actually goes out on raids with law enforcement when they're going out and thinking that there's something going on that they need to intervene on the outside. So what you start to find is individuals who have additional special gifts or interests in this space to help support clients. But it's really important that everybody understands their lanes about what role you're going to play versus your community partners, again, to wrap around an individual that makes a disclosure without there being turfing or conflict or confusion. The same for us was true in the world of the services with domestic violence shelters, right? Because they also provide housing and shelter and support, and people may make a disclosure to them. And so, what is the relationship between the shelter and us and the Anti-Human Trafficking Coalition? So, in our world, these 3 entities, us, the Anti-Trafficking Coalition, and the DV shelters, we had to be clear about our roles. our boundaries, our communication pathways, and at the end of the day, work towards documenting all of that in MOUs. Now, we certainly don't have all of our MOUs and documents done. That's part of the work we're still doing, but really boundaries and boundary clarity in response was something that was really important to us. We also have embedded some team members down at what's called the Ada County Victim Services Center. So in our system, if an individual is making a disclosure of a crime, they go there, and that's where law enforcement is, the prosecuting attorneys, health and welfare, victim witness coordinators. So one of the other ways that we could integrate our work into that ecosystem was to put a counselor down there. So we now have 2 counselors and a patient navigator that are co-located down there. So it's a different pathway, right? So if an individual has made a disclosure, they go through and work with law enforcement or the Department of Health and Welfare. They do their screenings. Our team member is there, so then we can pick them up afterwards to begin immediate counseling post-disclosure. So in this model, we're not the one that's maybe making the initial identification, but again, wrapping around and supporting once a disclosure has been made. So that we could help support an individual, and then they can either move to one of our long-term counseling centers or someone else in the community. So it's a way for us to wrap ourselves around the services that are being provided within our community for victims of human trafficking and intimate partner violence. Another way that people end up having a pathway into us is our protective parenting classes. So we have created programming in partnership with the Department of Health and Welfare for a 32-hour class. It's part of the care plans. Sometimes what happens in a system is that kids are removed from the care of their parents when there's been a crime or concern of a crime. And part of the reunification plan is about creating strength, resiliency, and capacity for positive parenting in the parent that is going to retain custody or get custody of the child back. So in this case, we partner with the department to do our very best to help parents develop their supportive parenting capacity so that a child can be returned back into their home. So in all of this work, as I mentioned before, right, the Human Trafficking Coalition, the Crime Victims Comp, and the 2 family justice centers are important, but so are relationships with the Department of Health and Welfare, the forensic interviewers, and the domestic violence shelters. So as you think about your journey with this work, again, as I said, it's not about being in an isolation. You have to start to think about what are also the different pathways where you may end up having strengths and resources that you can bring to the system, in addition to just the screening or the initial screening that you may want to think about weaving in to your primary care or dental practices, right? So a lot of people, as you start to step into this space, are doing similar work. And again, for all of us, it was really about understanding our lanes and how this is creating a tapestry to support individuals without there being confusion. And when you have this many entities involved, it's easy for things to get confusing for the individuals that we're all really well-intended and wanting to try and help. So that's a whole bunch in a really short period of time. So I'm going to pause for a minute. Because one of the things that is important to me is like that's how the system is structured. Those are some things that we think about when we are putting our model together. But I'd like to introduce you to some of the team members who are doing the work and thinking about how this work fits within what it means to be a health center and our vision for where we want to fit into the ecosystem here within our community. So if I did this right, we even planned and practiced ahead of time, my video will work. And I would love to introduce you to some of our team members.
Everyone's lives are affected by trauma in some way, either directly or indirectly. So no matter where they enter Terry Riley, be it medical, dental, pharmacy, or behavioral health care, we have a trauma-informed lens in how we care for them.
Well, trauma is everything. I mean, trauma affects everything. It affects how we parent, our partnerships, our friendships, even how we are with our coworkers. And unresolved trauma affects our ability to protect ourselves and protect our loved ones.
When we're talking about health and the physical health of a person, research strongly supports that if a person has unresolved trauma, their life expectancy and lifespan is diminished. We know that the psychological effects and scarring on people oftentimes leads to coping strategies that don't work or do damage. And so understanding health, which is our organizational concept and directive, we would have to look at this element, because without it, we're doing disservice to the clients. My role is a little bit unique. We're a restorative justice program, so typically what we are doing is working with people who create events that are abusive in nature and can create trauma. Work with people who've committed sexual battery or sexual assaults, sexual abuse of some sort, as well as domestic battery and abuse. I would say what sets Terry Riley apart is a organizational, from top down focus on the wholeness of the client that we work with. It doesn't matter what you've done, it doesn't matter what you do, what you're looking for help with. We're going to do what we can to try to truly understand who you are and help fill those spaces that you need help with.
Terry Riley also provides complete healthcare services for people in shelters and Boise's permanent supportive housing initiatives, including New Path Housing, where the impact of trauma can be part of daily life.
I work with a lot of people who are unhoused, and I think one way that Terry Riley addresses trauma is in taking, a special interest in care with people who have been experiencing homelessness. When we can help people get into housing and then help support them to maintain housing, we're helping them have that safe place and that refuge.
The constant exposure to vicarious trauma and compassion fatigue are challenging for therapists, so Terry Riley emphasizes self-care and resilience building for its team.
I think we're really good at Terry Riley about making sure that people are taking care of themselves. We want them to prioritize their own health.
It's really important for my team and myself to have a place to debrief and get feedback and guidance, and also just to be able to acknowledge that slow progress and improvements is still improvement.
And that slow progress over time reminds us that from dark places, there is still room for hope.
I work with these people directly, but my impact is on their kids, their friends, their family, their spouses, and the effect that their behavior has on them. And whatever I can do to help make their lives better, in the grand scheme, it is win-win-win.
Oh, I forgot. How am I supposed to get out of this? Hold on.
Yeah, just close it out.
Yay.
There you go.
There we go. So hopefully, while the video wasn't specifically on intimate partner violence and human trafficking, I wanted to share it with you because, I can put words to and describe, here are the steps, right? We went through and thought about, how do we support our employees? How do we create a culture? How do we invest in training? How do we provide tools? And make sure that we've got internal handoffs. But at the end of the day, is the team members, like the ones that you just heard a little bit from, that are the heart behind the work that we do, and demonstrate the commitment to the work that we're trying to achieve on behalf of our clients and the people that I trust, or that trust us with their needs. As I mentioned, our journey is not done. This is a perpetual body of work that we will continue to iterate on as we try to get better and better on behalf of our clients. So we continue to look for ways that we can support our employees. As Brittany mentioned, secondary or vicarious trauma, in addition to personal traumas, are something that we need to continue to be mindful of and think about how we build out our employee well-being and wellness supports. So this is work that continues for our organization as we talk more and more about how we support our workforce. We're also continuing to make investments in how to help support the first responders that I mentioned that are in the clinics. So how do we help continue to develop their skills to be present and available and supportive, and bring on some additional first responders? And as I mentioned, with our law enforcement or our security team members, part of what they're doing is constantly going around and working with team members informally. It's not structured formal classes, but informally being present, and helping to create a sense of safety, but also a lens or eye for safety and security within our team members. So that is ongoing work for us, as is continuing to think about our culture. And how we promote ourselves as a safe space for clients and people who trust us with their healthcare needs. So that work will continue to go on as we continue to get better and better. And then we're also thinking about different ways to make sure that we're being culturally and linguistically appropriate in the responses and the work that we do. As I mentioned in the very beginning, in our health center, English and Spanish are the dominant language. And Hispanic and Caucasian are the primary cultures, but they're not the only ones. And so if we think about our refugee community in particular, how do we make sure that we're being culturally and linguistically responsive in what we're doing for other people who come to our health center? So our work is not yet done, but we're feeling really good about the foundation that we've put in place. What I will tell you is the work that I just described took us about a year. By the time we think about the investments we made in the team members who led the work, and then the methodical, systematic way that they rolled this through our organization to get from where we started to where we are now, was at about a year's time to move our organization forward. So this is rewarding work. It's something that we're weaving into the fabric of who we are. It's not just a one-off project. It's part of our organizational culture, but that requires time and nurturing to help make sure that we carry it forward. So with all of that, I'm happy. I didn't notice any chats come up or questions come up in the chat, but I did want to pause because I know I went through a whole bunch of material in a really short period of time, and wanted to see if there's questions that you all might want to ask of me that I can share before we wrap up for today.
Yes, you're right, Heidi. We don't yet have anything in the chat box. So I would like to invite, if it's easier and you want to just come off of mute and ask your question of Heidi, you're absolutely welcome to. Or you can put them in the chat and I can read them out, whichever you are more comfortable with. It looks like we've got someone, Cody has come on camera. Do you have a question for us?
Yes, I'm sorry, you have to see me. So really, like from the beginning, it sounds like you have a really great relationship with your patients that has the foundation where they can like trust you enough to really kind of tell you the things that they've told you. What could you point to maybe some of the strategies or things that you've done to create that before you implemented any of this human trafficking response type stuff? Like how did you, what are the your ingredients for maintaining and building and creating that trust with your communities that you serve?
Oh gosh, I don't know that I have a great answer for that. I will do my very best. I think that one of the things that we have consistently worked on as an organization is, certainly you hire great people who love and support the work that you do. But at the same time, over the last couple of years, we've been doing a lot of training around our journey to be a CCBHC. Right. So there's lots of behavioral health related training that gets woven in there to create some softer skills for team members. One of our medical director is a real firm believer in motivational interviewing, for example. So that's been part of the training that we've been rolling out to our team members. And then we have a really strong patient navigator, community health worker, promotora, whatever language you use in your health center, They do tons of outreach, and that started pre-COVID. So I think that team members being out in the community, developing relationships, being present, as well as the skill development of our team members, I would put those two together to say it's creating this neural pathway within our team members and within the community to come to us for help.
Awesome.
Yeah.
Excellent. Do we have anything from anyone else? Scrolling through images here real quick. Make sure I'm not seeing any hands. Excellent. Well, while you all are thinking of your fantastic questions, because we do have just a couple more minutes, I did want to share that we do have our evaluation located in the chat. Of course, it's very important to CHAMPS, your State Primary Care Association, and our federal funders that we hear from you all and get your opinions. It'll take less than a minute to complete that survey for us. And then, as Heidi mentioned, our next session, we're taking the month of July off, but we'll be back in August. So on Thursday, August 21st, we will be hearing from Dr. Kimberly Chang from Asian Health Services and Futures Without Violence. And she's going to be speaking to the clinical considerations, best practices for health centers, and their response to IPV and human trafficking. We will be sending the handouts out in a follow-up, and we'll link to some of those great things that Heidi pulled out in her presentation today. And then the recording will be available probably a little bit later this week. So we do hope you'll share that with your colleagues. And I'm still not seeing anything in the chat. So with that, I want to say, Heidi, thank you so much. This was really fantastic, and we really appreciate you taking the time to share your expertise and your fantastic program with us. I think you've given everyone a lot to think about and to get started. So I really appreciate that. And thank you to all of you who joined us over your lunch break today. Thank you guys so much.
Thanks for having us. Thanks for your time, Heidi.
Thanks for the time, everybody. Have a good one.